my name's David Veale, and I'm a consultant psychiatrist in cognitive behavioural psychotherapies at the South London Maudsley NHS Foundation Trust, and I'm a visiting professor at the Institute of Psychiatry at the King's College London. So this webinar for the BDD Foundation is on navigating the NHS, because I'm aware, or we're aware, that it can be a bit difficult and not always sure who to go to or where to go to and so on. So, why doesn't my thing work? Sorry. I'm going to be covering today adults, and obviously in the NHS, and Amita Jazzy in a few weeks will be covering young people. The cut-off age is usually about the age of 18, but not always. I mean, there are some services, I noticed, even in my own service, actually, we've got a cut-off age of 17 and a half. So obviously we're covering body dysmorphic disorder, but most of the advice today also covers for people with OCD as well, most of it. And I'm date stamping it as being October 2024, because, you know, if you're watching this a year later, some of the details may be different. And we're also covering England, because outside England, in other words, things like Wales, Northern Ireland and the islands, do not have specialist services for BDD, but you can, you know, it's still part of the NHS, you can be referred to a service in England. It's just that it's even more complicated. In Scotland, they do have specialist pathways for OCD in the Dundee Advanced Intervention Service, but I noticed on the website that they don't cover BDD. But all the same, again, the Scots can refer you to a specialist service in England. So it's just, you know, I can really only talk for what I know about in England. Now, we know that BDD is common. It's, you know, 2% of adults in the community have got BDD. But here's the thing. It's relatively uncommon presentation in mental health services. Some people present with another problem, for example, like depression, social anxiety, OCD or something, when actually the main problem is the BDD. But, you know, I think many people don't present at all, or if they do present, of course, they're more likely to be going to cosmetic surgery, dermatology services, where it's thought to make up about 10% of the population within such clinics. So, you know, large numbers of people we know need treatment, help. And I would recommend downloading this guidance, the one from NICE. This was something I was part of in writing in, 2005. And it's still a good document to use when you're arguing perhaps for the right pathway in terms of treatment. What it says essentially is, and this is, you know, it's combined with OCD, if you've got mild function impairment, you should be getting perhaps brief CBT, which essentially means, you know, this is a tricky one because it's really more geared towards OCD. And we'll talk about what's actually offered usually in the primary care shortly. If you've got moderate function impairment, you should be offered either CBT or an SSRI. And with more severe function impairment, you should be offered a combination of CBT and an SSRI. You know, there's the sort of very broad treatment guidelines which still exist, I'm afraid. I'm afraid our research has not moved on since then. There's lots of possible things on the horizon, but I'm afraid that's still, you know, the treatment choices. One of the questions sometimes is, have you had CBT for BDD? And sometimes people are told this is what they're going to get, but it's quite, you know, it's not like taking Prozac or a drug or something which, you can know that what you're taking is the drug that it's on the label, and all you have to do is to follow the instructions in terms of the dose and duration, things like that. The problem is trying to make a judgment in terms of the quality of CBT perhaps you might have had for the BDD. Now, this is like a whole webinar in itself, but in general, you want to have had a good understanding of perhaps the development of your problem, and really perhaps understand, if relevant, some of the associations made about your body image when you were younger. And it may be necessary to try and help you to update those memories. The focus is primarily on the maintenance factors, all the avoidance, the safety-seeking behaviours, the checking, the ruminating, the comparing, the self-focused attention, and some of the beliefs that you might have about the ruminating, comparing, and so on, and the motivation behind them. It's important to be able to help you, therefore, to be able to give up those safety-seeking behaviours and to try to get you out of your head and do the things which you're avoiding without the safety behaviours. And it's tough. It requires a lot of courage. So it's important to be able to try and agree with your therapist on the problems, the goals, and an alternative understanding of the problem, was sometimes referred to as theory B. The most important, therefore, is going to be the homework between the sessions of exposure, testing out your alternative theory, trying to disengage from those excessive behaviours of the checking and all the ruminating and the comparing. That's a very brief nutshell of what CBT for BDD is. So let's think about how these things are applied in the NHS. So the term that's used for virtually all disorders is stepped care. So we have to think about 3 different levels of care. Primary care, which is essentially your GP and talking therapy services. The secondary care is what we call the community mental health teams, which are multidisciplinary teams. And lastly, tertiary care, which is your specialist services, again, a multidisciplinary team. And you'll find these, really used throughout treatment of BDD. It doesn't mean you have to slavishly go through each of these steps, because sometimes it's appropriate to be referred, to the appropriate. You have to be referred to the appropriate level, and you shouldn't have to sort of slavishly go through those different steps when it's not appropriate. That's sometimes, I think, when it's misused in many ways. So let's think about primary care. So primary care is essentially a GP level. So GPs can, of course, prescribe the appropriate medication. These are things like fluoxetine, escitalopram, citalopram, sertraline. GPs may lack confidence about increasing the dose to the maximum tolerated, but that's what's licensed and recommended for OCD and therefore BDD. Often, you may do better at higher doses, and that's usually what would be recommended. Now, the GP can also refer you to a local talking therapist or another provider under the patient choice scheme, or your CMHT. So that's why they're important to sort of first step into the system. Remember, actually, when I talk about talking therapies, that's the new word for improving access to psychological therapies, the IAP services. There will be a local talking therapist or IAP service at every town, near you, as it were. And you just have to type in talking therapies, Doncaster, where it is you live. So let's talk about talking therapies. As I said, you can be referred by your GP, or if you prefer, many of them will now actually do self-referral. And that may include talking to an AI bot on their website about your problem, and then they will organise this sort of appointment for you. I've never actually tried out those AI bots, and actually what happens if you've got BDD and type in, I feel ugly, and does it actually get you to the appropriate appointment? So remember, with talking therapies, there are two levels of service. One is done by the psychological well-being practitioners, or PWPs. Now, I don't think it's appropriate for people with BDD to be seen at that level. This is a very helpful service for people with depression and anxiety, and you may well be assigned to a group which is for depression and anxiety, or you might get a computer program or a specific workbook, perhaps sometimes for BDD, to work through. So we haven't got a good evidence base for that approach so far. I mean, there are a few new computer programs coming out for BDD. As far as I'm aware, they're not yet introduced in the NHS at the moment for most IAP services. But I'm just saying it may be, and I'd be keen to hear if you do hear about it. The second level of talking therapy services is the cognitive behaviour therapy, either by a trainee under supervision or a trained therapist. So the first thing to do is just check, I think, the protocol they're using. Is it specific for BDD? You will probably be offered about 12 to 15 sessions. And I think that's part of the problem sometimes. You may be able to get more. I think, we know that BDD is tricky to treat, and you often need more sessions. But if you can imagine you are one of these talking therapist services, they have a limited resource in terms of the number of people they can treat and things like this. So it is partly to do with that. I'm just saying, you should have a minimum of 12 to 15 sessions, and it should be following a protocol for CBT for BDD. I mean, the results in NHS talking therapy is not bad. You should be asked to monitor your progress with a body image questionnaire. It's the same one we use on the BDD Foundation website, and probably a depression scale. And I couldn't yet get the national results, but I did go to one of our local talking therapy services around the Maudsley, and I got the results that 50% of their patients with BDD had achieved recovery after treatment, and 61% had achieved reliable improvement. Now that's not bad. When you for most, when you compare it against recovery rates in depression and other anxiety disorders, that is the target for a talking therapy services, to get 50% recovery and usually about 60-70% getting reliable improvement. So what I've seen so far, it's not bad, but it'd be interesting and helpful to see that confirmed in the future. Now, the other alternative, if you don't want to go to your local talking therapist services, is to use what we call patient choice at the level of primary care, because you and your GP have a right to refer you to any outpatient service, even if there's a good local service, all right? And you're talking about the equivalent of a talking therapist, so that you may be offered 12 to 15 sessions. However, this is something that we do at our own service at the Centre for Anxiety Disorders and Trauma at the Maudsley. Now, when the team that you're referred to does their own assessment, they may occasionally decline a referral and recommend you be referred to your community mental health team. Perhaps they might be concerned about your level of risk, or they may feel that perhaps there is another problem there that needs also to be tackled. So the key thing is always about risk, and perhaps do you need to be under a community mental health team and get local support at the same time. So the outcome of that assessment at a patient choice place like Cadet is they might recommend you to a different service, or to put you on the wait list for treatment. or perhaps suggest that you should have a more intensive program at a higher level of treatment, not in primary care. So that's patient choice. So let's assume, so primary care we've been talking about. Now let's talk about secondary care and community mental health teams. One of the things that's always baffles me, to be honest, is often how secondary care is organised, because, to be honest, there are so many other different things going on. There could be an assertive outreach team, an early intervention team, a recovery team, and so on. It's just appalling in terms of continuity of care. But, you know, I'm afraid this is the way that it's also piecemeal service. It's not in all services, but there should be a community mental health team that will primarily have the role of making a diagnosis, doing risk assessments, being able to recommend your GP, perhaps prescribing medication, and they may make a referral to a specialist service or tertiary care. So within a secondary care team will be a consultant psychiatrist, if you get to see them, or it could sometimes be what you call an associate specialist, is someone who's had the training as a psychiatrist but is not quite a consultant, as it were. Or it could be what's now called a resident psychiatrist, which is a trainee psychiatrist. So you may see one of those. You may be allocated, you should be allocated a care coordinator who does what they do on the tin in terms of coordinate your care. And there should be a psychologist who could be delivering the CBT for BDD. But I have to say that in many CMHTs, psychological therapies are decimated. You know, they've got very long waiting lists. The NHS is very aware of this at NHS England level, and there is a strong desire to develop those psychological therapies and help it expand. But I'm just saying, right now in October 2024, this is where the problem lies in terms of trying to get getting any CBT for BDD at secondary care level. Yeah. So what about tertiary care? So tertiary care, I'm saying, is you need to get referred by your secondary care team, your community mental health team, care coordinator or consultant. And there are three different levels within the tertiary care. It could be outpatient, where ones might be our own service again at the Centre for Anxiety Disorders and Trauma, CADAT, at the Maudsley. It could be at Oxford, the OSPIC specialist services. I don't know a lot about that because they're mainly working with OCD. Or it could be, say, at QE2 Hospital, Welwyn. So essentially these are outpatient services where you might attend once, sometimes twice weekly or something, and get the CBT delivered in that way. It's preferable to do it face-to-face. Sometimes some of the sessions could be done remotely, like now, over the video, but it's usually preferable to be doing it face-to-face. The next level up is at our anxiety disorders residential unit. This also refers to an ADRU, and that's the little picture there. This is at the Bethlehem Royal for up to 16 weeks. Now, at the residential unit, there's no staff outside 9 to 5. There's no nursing care. And you can think of it more like a sort of a therapeutic community, which is a hostel. In other words, you get bed and breakfast and meals and all the therapy and occupational therapy and so on, but there's no nursing care, and therefore it can't take people who may be a suicide risk or neglecting themselves and need perhaps help with their medication or things like that, all the things that would be necessary for nursing care. I'm very proud of the Anxiety Disorders Residential Unit. We've just been shortlisted for the Mental Health Team of the Year, and we think we can provide a good service for people with BDD there. Lastly, there is inpatient services such as Springfield, where you may go, I think, up to 6 months, 4 to 6 months. And that's done by Dr. Pampaloni. But again, for all of these levels, you must be referred, and when you're discharged, go back to your secondary care team. Yeah, you can't get it any other way. You can't be referred by your GP or a private specialist as such. Yeah? So you have to be referred by your community mental health team. Now, what about funding for tertiary care? So the current name for funding, which used to be Commission Care Group, CCGs, is now called Integrated Care Boards. As I said, if you're watching this a year or two later, it's probably changed its name again. But the purpose here is to try to integrate care and between the providers and the commissioners. And I think eventually with social care as well. But this is what they're called, integrated care boards. So for you to get that referral and funding, as it were, you must have the support of your CMHT, because they're going to have to write out an application form to the integrated care board and argue why you should be referred. Now remember that ICBs have many competing demands. They will get requests for such and such to go and get treatment for their leukemia or this, that, and the other. And so I have to say sometimes they will be looking for reasons for rejecting the application. And the most common is, for example, that you've not exhausted local services, which is a really tough one to argue against. So always get their decision in writing, as you can then appeal and understand what it is that they're talking about if they are rejecting you. I mean, these things usually go on behind closed doors. If we get a referral at Cadat or ADRU, then our funding departments will contact the ICB, and it just sort of all happens in the background. And most of the time it's just done routinely and just goes through, but I'm just saying not always, and you should be kept informed and try to get things in writing if there's a problem. Now, the other stream of funding is national funding, what we call NHS England, the highly specialised service, HSS, for severe treatment refractory OCD and BDD. So this is a stream of funding. It's a bit like all the different ICBs pooling their funding for particular rare treatments. So, it's not, let's say someone needs a heart transplant or something, then it's a bit unfair if one particular ICB has to sort of fund 2 or 3 of them within their particular community. And so it's like an insurance policy. They all fund it together, the whole lot. And we do have this service, therefore, for OCD and BDD. In order to fulfill those criteria, to get this funding, you have to be in the severe category. That's measured on the Y box for BDD. You have to have had at least 2 trials of an SSRI at the maximum dose for at least 12 weeks. And you must have had at least 2 trials of CBT. That doesn't matter whether you're in the NHS or private. And you must have a care coordinator and not be discharged by the CMHT. And so when you get, if your CMHT has made a referral to one of those services I was talking about, then you get a assessment on the basis that you appear to have some of these most of these things, and then after the assessment, the information is taken to a clinical panel of those clinicians and all the different services that are part of the HSS, and then a decision is made then, and then you and your family are known, told what's happened. So the outcomes could be that where you had the assessment, you could be admitted to or seen as an outpatient. Sometimes the clinical panel will disagree with the recommendation. They may say, no, you haven't met that particular criteria, or that perhaps it would be better to be treated elsewhere, and so on. But that's the clinical panel that makes those decisions. So I know it's complicated, but it's not all bad news. Please try to, I know it's difficult enough just to have BDD, and it requires a lot of courage to get that treatment, but do persist. It is sometimes, I understand, painful. And if at first you don't succeed, get advocacy on the BDD Foundation helpline, try again. And you will get through. Eventually you will get the right treatment or the right care pathway. And I'm happy to, the BDD Foundation always asks me advice and so on about things in terms of what might happen, can happen. I'm happy to take questions because I suspect that might generate quite a few questions. Right. Does it matter if you've had CBT that's not specifically the BDD to meet the criteria? For example, I've had CBT for an eating disorder that was caused by BDD. Well, I don't want to be held to account on this. Look, if you are seen for an assessment, the person doing the assessment will try to understand the context and everything that's been going on. It doesn't strictly meet it, yeah, because sometimes people have had, as you say, CBT for depression or an eating disorder or something as you described, and so it's not really, it's probably not going to count, even though, well, it's difficult to know in your particular circumstances, so I can only answer in general terms, because as you say, the disordered eating, it's not really an eating disorder, the disordered eating might have been part of the BDD. So it probably does, but I'm saying it would need to be assessed formally. Yeah. Now then, Michelle has asked, I've been dropped repeatedly from my mental health team as they wanted to mistakenly assess me for ADHD. It was a mistake, but then told my needs are too complex for a social subscriber, so I'm left on long-term SSRIs. Okay, so again, it's difficult for me to answer a specific question like that. If it's a community mental health team, I mean, one of the problems of CMHTs is that they get overwhelmed and they are constantly trying to discharge people and really hold on only to those people who are suicidal and violent, or risks and all these sorts of problems. And then because they're trying to discharge you back to primary care or perhaps talking therapies, and talking therapies are trying to think that you're too complicated, so you should go up to secondary care and so on. It's an awful state of affairs. But this is odd for me that they want to assess you for ADHD. Again, that's often usually another specialist service with a long wait list. But now, as you say, your needs are too complex. Well, they may well be complex, but it shouldn't be a social subscriber. And you should be seen, in that case, if you're too complex, you should be seen by a consultant psychiatrist, have a proper assessment and a treatment care plan made in the way that I've described. Yeah. Next one. My daughter is currently 16 and a half years old. She's recently referred to the BDD service in the Maudsley Hospital, and the referral has been accepted. The wait list for assessment, oh God, is 12 months, yeah. This means she's likely to be 17 and a half at the point of assessment. It's then another 6 months for wait for treatment, which takes her to 18. What then for my daughter? I'm so sorry. The fact that she has been referred means that she will now be seen and, if taken on, treated at the Maudsley, yes, in their service. What they really focus on is getting the referral in before you're 18, yeah. And so if you've actually been taken on for an assessment and they believe that they can help you at treatment, they will do that, yeah. So if not, they will refer you then on to the adult services. So obviously I don't know exactly what that path, something will happen. You'll either be seen in the adolescent services or you'll be seen in the adult services. Yeah, does that make sense? Are there any issues, someone anonymous has said, are there issues with someone who's Asperger's getting help? Yeah, so Asperger's is the old name, of course, for being on the autistic spectrum. So no, many of our patients at the outpatients or ADRU is probably about at least a quarter now, 20-25% are on the autistic spectrum. If the autistic spectrum is the main problem and really gets in the way of everything, it's the main problem, then it's often better helped and seen within an autistic spectrum service. But the large majority of people are seen now within general psychiatry and specialist services like our own. And it's, for the system to adjust and adapt to your particular needs, whether it's the way that the therapy is delivered, particularly in terms of, not using too many abstract terms and so on. So no, there shouldn't be. I think you'll find that it's well recognised being on the autistic spectrum, and it's for the service to make adjustments. Yeah. Michelle says, I'd like to be referred to somewhere that can work with my BDDs. Right, so this is the problem, Michelle. When you have got more complex needs, and obviously it's severe needs, you can use in theory, the patient choice referral in primary care, but it may be, because of the severity of your condition, it may be not appropriate to be treated at that level, because it may only be 12 to 15 sessions, and then you need other problems and so on. So it's worth trying, but it may be the decision is that actually it's not appropriate at that particular level. Do you see what I mean? So Lindsay says, does application for national funding, for example, always go through the CMHT in the same way as ICB funding? No. In other words, if you and your team think that you fulfill those criteria that I laid out, then you make the referral and to the particular centre that's going to be hopefully treating you, and they do the assessment and they will decide on whether you fulfill those criteria, and then it's decided at the clinical panel. So you don't need to, the CMHT doesn't need to worry about going through the ICB funding or anything like that. Yes, someone's asked about North London Priory. Yes, it still provides inpatient care for BDD. That can be referred by the NHS, but it's usually done first, the referral for assessment down at the Springfield Hospital. Yeah. What happens if you can't tolerate maximum dose of the SSRIs? Tried 3 different ones. Well, again, talk to the person who does the assessment, because they will want to know in detail exactly what you're experiencing at the higher doses, and whether any adjustments can be made, or how they're going to, because they'll have to present to the clinical panel what the problems have been. And so it's very important to get as much detail as possible in terms of the side effects, and whether any attempt has been made to try to modify the medication or modify things so as to improve the side effects or whatever. Yeah. Next one says, I use alcohol to medicate my anxiety. I couldn't tolerate rehab due to the BD and social anxiety. Mental health services exclude me due to my drinking. Where do I turn to support? Oh dear, this is really difficult, isn't it? This is, I'm afraid, what we call silos. Every service does their own thing, and if you don't fulfill our criteria, then you have to go, down the road, and the other lot say the same thing. I mean, if you're using alcohol, it is very important to be alcohol free, because you can't really use medication or therapy whilst you're still using alcohol. I'm afraid it is just one of those things. So I understand what you're saying there. You can't tolerate rehab due to your BDD and social anxiety. Somehow, something has to happen. I mean, in an ideal world, you would get those treatments in parallel, wouldn't you? But I do understand that it is quite tough to do that in the NHS. It's difficult. I'm afraid it's difficult for me to answer right now on the Q&A, but it's a tricky one. I accept that entirely. But I think there is probably a way around it somehow. But it's difficult to know without actually seeing someone. Without. I can only really talk in general terms. Oh dear, Michelle, at 56, should I try to pursue treatment or just give up as I'm too old? No, Michelle, that is awful to hear. There's, plenty for you to be able to get help for and get a good quality of life at your age. So please do get help, even though you're, as you say, you're almost 57. I'm 68, 69, and I would still get help. Leanne says, I believe I have BDD. The GP referred me to a mental health practitioner. I'm not quite sure what a mental health practitioner is, what sort of level or training. She says I'm too complicated for her care, so I also put forward to a secondary care treatment, but keep being told I wouldn't be accepted. Oh, God. Well, there may be some truth in that, in the sense that there may be some very strict criteria that the secondary care mental health team are laying down, whether you're suicidal or whether you are violent and all these other things they may have for risk. And so this is what the awfulness of psychiatric care, I'm afraid. It's become a sort of risk assessment service. So I would argue with the the NICE guidelines about the need to be having a good assessment and recommendations for medication and if necessary, referral onwards to a specialist service. Or the only other thing you consider doing is trying to see whether you can get a referral using patient choice to a specialist provider, even if it's at the level of primary care. And that at least will get you a good assessment, and they will hopefully provide that therapy and advice on any medication. Or they will say, look, this is too complicated, you need to be, they'll have that recommendation, you need to be under a secondary care provider. So that will at least help you as well. Which funding pathway do you recommend going down to get specialist care? My care coordinator got stuck in the middle of the two, both saying it was the other funding panel's responsibility. ICBs versus NHS England. Well, again, without knowing the details, anonymous attendee, it's difficult to know, because if you get referred to a specialist service like Kadataraju or where I am based, they will look at what your care coordinator information they've given you in terms of the medication trials you've had or CBT trials that you've had and so on, and they will probably either do an assessment there and then, or they will tell the care coordinator, you won't be able to do this under the NHS England funding stream, but you will be able to do it under the ICB. So I would get the opinion or refer, via referral to one of those specialist services. So they should be able to say at either an assessment or the screening that they get from the referral letter. Yeah. So someone anonymous says, do older people, late 60s, have more problems accessing services? I mean, they shouldn't do. That would be ageist, and I don't understand why. No, they shouldn't do. We certainly wouldn't turn down a referral. So no, I would just keep pushing for that. I don't see why. I've never had CBT and advised to use talking therapies. You mentioned online possibilities for this. Is it possible to use a recommended app or something like this being used to BDD OC sufferers? Well, there are apps and computerized CBT that's being developed. There's one in the States and one from Sweden, but as far as I'm aware, they're not yet been adopted in the UK in the talking therapist services. The ones that might be recommended to you are probably more generic. Yeah, that they're not specific for BDD, and I really would recommend it needs to be specific to BDD. So I would get an assessment, and you can then talk through those possibilities at the talking therapist service. Victoria Holland says, do you have experience of working with autistic people who don't accept they have BDD? Well, it's not just people on the autistic spectrum who don't accept they have BDD, or it may be people without BDD and they don't believe they have BDD, or they may say, well, I've got BDD and a real defect, and so on, so on. So lots of there are variations on this. How can we break this kind of barrier down? Well, it is tough, it's very difficult, and we need to focus primarily on the handicap, the interference in their life, and how their solutions are their problems, and getting appropriate reading material and websites to focus on perhaps this is a recognized problem, and so on and so on. So there's no easy answer here, I'm afraid. Unfortunately, it's not the sort of service that is provided in the NHS, in the sense that you have to have some recognition that this may be something that you can do something about. Yeah, some insight into the problem. Anonymous sender, how's the waiting list for ADRI? Well, again, this is October 2024. It's not too bad at the moment. It's about a month or so. Whereas at Springfield, I think it's about 6 months. And for Cadet, it's about, it depends upon the funding stream. Yeah, it's too complicated. Gary says, I was diagnosed with BD 18. I'm now 42. I've been on so many different medications, yet nothing really stands out as working. CBD is very hit and miss on the NHS. I feel I'm wasting the psychiatrist's time and patience when I ask for a medication review or try to get suggest a further diagnosis or bipolar. What should it possibly be if I'm treatment resistant? Well, Gary, if you've been tried on lots of different medications and CBT, you're just the right sort of person who should get an assessment at one of the highly specialized services, because it sounds like you will tick all the boxes, and it may be that that they can then offer the appropriate treatments and therapy that perhaps you have had, or perhaps in a more intensive way, and so on. So again, it's difficult for me to comment without seeing you, as it were, but it certainly should be possible to get a referral for an assessment and to see there, whether perhaps it might be able to help. After 5 years of fluctuating improvements from BDD following inpatient tertiary specialist treatment, I'm now experiencing lapses and difficulty leaving the house. How should I expect the NHS services to support me? Well, you can get a re-referral back to a specialist service to have a top-up, whether it's as an outpatient or as residential unit and so on. However, as you say, the NHS secondary care team should, it would be nice if they could also provide that therapy and support. As we indicated earlier, unfortunately, many of the psychological therapies at a secondary care level is often very overstretched with very long wait lists. So it may be easier to try and diffuse this and see if you can get them to, refer you back to one of the tertiary care specialist services. Michelle, I'm currently receiving support from the Life Centre and halfway through the allocated sessions. Now, I don't know what the Life Centre is. I assume it's at the level of talking therapies in primary care. Would it be possible to ask my therapist to do some sort of letter to recommend I be put on a waiting list for support for my BDD? Well, I think if near the end of your treatment, it may be that your therapist, you and the therapist can review your progress, and it may be that your therapist can then recommend to your GP or the community mental health team about getting a referral onwards to a specialist service or whatever. That's certainly possible, but keep going and really make sure you carry out the treatment that's being offered. Jenny says, hello, I've never taken SSRIs for BDD. I'm 47 and then perimenopausal, feeling about re-triggered at times, skin face changing naturally, and first time I feel like it'd be a good idea. I have the lowest dose of sertraline prescribed to me. Should I start there or go back and see if I can get a higher dose? Is there an SSRI that's better for BDD or trial and error? I'm afraid there is no one which has been shown to be more effective for BDD. It is trial and error. Some people do slightly better on one rather than another. Certainly I don't know how long you've been on the sertraline for, but if you've had a good crack at it, it's certainly worth trying to gradually increase it up to 200. But again, this is general advice. That would be what the recommendations are for using SSRIs. Anonymous attendee, which funding is best to try from Northern Ireland? Well, I'm afraid I'm not an expert on funding in Northern Ireland. It is part of the NHS. And if you feel that you've not made progress locally, then you can ask your local consultants or care coordinator to refer you to a specialist service in England, because there isn't any specialist service in Northern Ireland for BDD. One more. Are there any specialist services in the north of England? Not ones that would be specifically recognised for BDD or OCD. There is in Newcastle a Centre for Cognitive Behaviour Therapy. That might be probably the next step to go to if you want to go to see someone face to face up there. All right, thank you.
That was really, really helpful, David, and a great overview. And you can, of course, email any more questions in to support@bddfoundation.org, and we'll do our best to support you at whatever stage you're at in accessing treatment, because we know it is difficult.